For those of you who don't know me, my name is Lorinette Wirth. I am a PhD student at St. Louis University in the Center for Health Outcomes Research. On the left, you will find my PhD advisor, Dr. Leslie Hinyard. But I want to present to you my project called Racial and Ethnic Disparities in Healthcare Value Across Comorbidity Clusters Among Cancer Survivors. And I told you it was a lot. So I'm going to point your eyes to three distinct themes that I want you to kind of remember during this presentation. There's theme 1, racial and ethnic disparities. There's theme 2, healthcare value. And then we're going to look at comorbidity clusters. So most of you have probably seen that top figure or some statistics relating to that top figure during your public health career. The United States isn't doing so hot when it comes to healthcare. Or healthcare costs a lot. In fact, it's the costliest in the world. While our quality of care when ranked among other wealthy nations suck. Okay? So this is a problem, right? We are, of course, the United States. And so the Institute for Healthcare Improvement, IHI, one of the global leaders in healthcare quality, developed this framework called the Triple Aim. And essentially they said in order for us to improve our healthcare quality, we need to focus on these three things. Or population health, and by that they're referring to overall quality of life of health. And by quality of life, I'm referring to the mental and physical aspects as reported by a patient, and maybe how the diseases that they have might affect that. But then not only that, we want to focus on per capita cost. So that's the cost per population member per month. So we want the lowest possible cost with the highest possible population health. But that's not it. We also say we want our population to have a good experience when it comes to healthcare. When you fill out those patient satisfaction surveys, we want great scores. So, but also notice that these things work together. They're not in silo, right? If you lower the cost of healthcare, you're going to have better patient experience. And also if you make population health better, in return, your healthcare is going to be lower because you're going to have less, emergency room visits and so forth. So it all works together. But all the clinicians were like, whoa, this is not fair. These are a lot of things that we have to do, and you're not making it any easier for us. So they said there's a missing aim. We ought to focus on the clinician experience as well. And I said, all right, you're right. So the first thing that popped into my mind in seeing this was precision medicine. And for those of you who don't really know what precision medicine is, it's really saying that in order to enhance healthcare delivery, we need to create a customized healthcare plan for people. Because if we create this customized healthcare plan, then we're not wasting resources. It's a more targeted care, instead of a one-size-fits-all kind of squandering money everywhere, not really, getting to what we need to get to. But you might say, well, that's still pretty expensive, especially when you're dealing with a low-resource country. So how can you still have precision medicine, but have it more attainable? Especially, yes, in the US, but also in other countries where maybe they don't have the technologies yet. So then you think about subgroups and clustering. If you can customize healthcare for sub-portions of your population, you're still providing customizable healthcare. You're just still doing it to a higher level. But at least it's still not a one-size-fits-all for everybody. So we talked a little bit about population health, and we said that when we talk about population health in that triangle, we're really referring to, at least one of the aspects we're referring to is this term health-related quality of life. And really what that is, it's a patient-reported outcome. That means the doctor can't report for you, right? It's a patient reporting for themselves. It's a subjective perspective about how they feel. And specifically, when you're talking about the short form 12, which is a questionnaire, it's a 12-question questionnaire, it digs into aspects related to mental health. So that might be the role limitations mentally related and other mental health problems. Or it might be questions related to physical health. And that might be like bodily pain or other role limitations related to physical health. So there is an algorithm that weights these questions and gives it a score from 0 to 100, 100 being perfect health. But the interesting thing with using this SF12 is that then you're able to convert it to what's called a utility measure called SF6D, which, when taken into consideration with time since you've been living with an experience, can tell you something about this term called quality adjusted life year. And that goes back to the point that, yes, and this is what we've been focusing on in our past healthcare, is we want patients to live longer. It has always been mortality, 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 time to mortality. But now we're coming to realize it's not all about how long a patient lives, right? If you have someone who lives till 80, but, from 60 to 80 they were miserable, versus someone who only lived till 70, but maybe from 30 to 70 they were in great health, the 70-year-old actually lived a more quality life. So it's how do you adjust for that quality component? And that's how this health-related quality of life aspect gets compounded with the time spent in that state. And just to clarify, by state, it's the state at which they're reporting that quality of life aspect, if that makes sense. And you're going to get this quality. So stepping back and kind of remembering that framework, because we're going to try to hit at somewhat all of those different points in that triangle. The goal as a society, right, is now we want that quality, but we want it at the lowest possible cost. And that's where healthcare value starts to come in. Okay? Keep that in mind. So I'm throwing around this word quality, quality, quality. What do we mean by quality anyways? And the Institute of Medicine kind of have this, I don't even know what you call it, but this graphic. And they have these domains that they're after quality as. And I'm just going to touch on efficiency and effectiveness, and I'll tie those two together. So effectiveness, we definitely want whatever we're doing to work, right? But we want it to be efficient. So we want to use our resources in the best manner possible, or cost effective. We want it to be patient-centered, which is a key theme. And that goes back to that quality of life aspect where it's patient-reported, okay? And then also I have highlighted here is equity. And remember I said there are some themes, racial and ethnic disparities, that's where ethnic equity is going to come in. So we want not only for across racial and ethnic groups, and I'm generally focusing on racial and ethnic disparities, so not only do we want those groups to have similar outcomes, but we want the cost to get those outcomes to be similar. Right? So we don't want one group to have greater outcomes at a lower cost, while maybe one group has that same outcomes, but you have to be all the way up here in expenditure. So when I think of this, I think machine learning, okay? And machine learning, you can split it into unsupervised machine learning and unsupervised machine learning. And it's a sub-branch of artificial intelligence and statistics. And essentially it allows you to break population, in my example, into these clusters or subgroups, so then that you can later look at. And I included this slide because I want to show you that this area is pretty new. Like if you look at the times, it's 2017, 2017, 2017. Patient reported outcomes 2015. So a lot of work left to be done here. So a lot of people have looked at comorbidity clusters, or not a lot, but the few that have not done it in cancer. So there's a gap to be filled. Also, a lot of papers that look or that identify clusters, they stop at cluster identification. They say, hey, here's some clusters we have, and then they don't do anything else with it. So we're going to go ahead and look at how racial disparities interact with clusters. And then also we're going to look at that cost component. So that cost paid per quality adjusted life years gained. And we know that the issue has been raised that we need to look at this from a racial and ethnic disparity standpoint. Now, ignore the first two aims for now. I'm going to skip to the second, the last two. But, so, big project. I warned you guys. The first one, we're going to look at racial and ethnic disparities in health-related quality of life, which we know exists, but we want to see if, is that based on what cluster, disease cluster a patient falls in. And then we also know, does cluster on its own also tell us something about health-related quality of life? And then we're going to really do the same thing, but using cost utility as that outcome. And I said skip the first two. The second aim, it's kind of obvious, right? You have to actually identify the cluster, so it's this unspoken aim. And then I mentioned the first one just because in my proposal I had mentioned and we dropped it. But I was able to gather a group over the summer to work on it, and we are one conclusion section away from submission. So, throw that out there. So I worked with MEPS, which is a nationally representative data. It's the Medical Expenditure Panel Survey. I used years 2011 to 2014. And this specific survey is really complex to work with, though very rich in data. They have medical events in one file, and then they have expenditures in another, and then they have your socio-demographics. So I had to go through, I used panels 16, 17, and 18, and when I say panels, they're like cohorts. So they're actually going to follow up 4 times with each person in the MEPS survey. So after I selected cancer comorbidities, so any disease that's not due to cancer, but of course aside cancer, and I can tell you later how I selected these comorbidities, but I brought that into a file, right? So now I have each record of patient, and then I have variables with all their diseases, binary variables, and I created clusters, comorbidity clusters, which I then linked back to, using the ID, to my file that includes my socio-demographic variables, my health-related quality of life variables. Then I was able to convert that to QALYs, quality-adjusted life years, through an algorithm that Dr. Brazier supplies at the University of Sheffield, which left me with 3,112 cancer records. Not going to dig too much into this. I used multiple clustering algorithms. I'm only going to go over the decision tree for time's sake, but I used linear regression, a multivariate linear regression, and the cost utility analysis. So this is what a decision tree looks like. And actually the 2 pictures are the same, top and bottom. I just think the bottom one's a little easier to see. But you can see there that, so these are the 3,112 patients. And these are how they were clustered for the decision tree. And you can see that they're distinct groupings that you can identify when you have this algorithm do this. So to my first questions, can these patients be subgrouped in a manner? I would say yes, they can. And this is just one algorithm, and you can go back. But then you ask the question, what does these clusters mean? Like when you use it as an independent factor in, trying to assess the association with health-related quality of life, we find that these clusters are independently associated with physical health and mental health, health-related quality of life. And this is after adjusting for the number of comorbidities, sex, poverty level, smoking status, age, body mass index, insurance status, education level, and marital status. So we did find, though, that interaction term, so we found that the cluster that you were in didn't affect whether racial and ethnic disparities exist, which I don't know if that makes me feel better or worse. But so when it comes to cost utility analysis, I found that the 2014 data did not have time since cancer diagnosis, and so I need to actually go back, and I'll just throw out the 2. I was going to predict it using a predictive model, but I can just use 2013 data and make my life a whole lot easier. But I wanted to show you pretty much what we've been looking at. So this is this SF6D, that the only thing I need here to turn into QALYs is to multiply it by the time since diagnosis. So assuming that my time since diagnosis is the same, we know this is not true, but this is just for, I want you guys to see how this looks. Whites, non-Hispanics whites is that red line, and non-Hispanic blacks is that green line. And we see that their QALYs is around the same, about 0.6, maybe whites are about half a point greater. But if you compare the cost spent, the expenditure cost, we see that whites are at about 3,500, while non-Hispanic blacks are about 5,000. So you're seeing that discrepancy there. Now, this is not adjusted for. Again, this is not QALYs. This does not take into time spent in that state. So no conclusion drawn here. I just want you to see. So going forward, I need to go back to all those methods that I used to identify clusters. I need to really decide on which clusters I want to use, because they're going to throw out slightly different results. Also, in the way you interpret those results might be slightly different. It takes some expert opinion to really say which one should we use. I'm not going to go back and build that predictive model to try to pick up on age at cancer diagnosis. I'm just going to use the 2013 data. A big thing so this is a generic health-related quality of life measure, which means that it's not cancer-specific. It doesn't necessarily ask questions that directly pertain to cancer. And so I might be missing things that I need to be asking to a cancer patient, but you use what you have. I also threw all of the cancers right together. Someone could argue, well, you need to stratify by cancer type. The sample size doesn't really allow for that. So again, you use what you have, but I would expect that the relationship with health-related quality of life would be similar across cancer. I need to go back and, especially as I'm doing the cost utility analysis, that's what that ICER is. I want to match, match the covariates on the racial and ethnic groups to adjust for confounding. And then also the cost that I'd use in this analysis looks at direct medical costs, so that's the cost insurance is paying, and also any out-of-pocket costs. It doesn't take into consideration maybe costs related to transporting yourself to the facility, or costs related to time missed from work or school or babysitting, which I think are really important to look at from a societal perspective. There is an experiences with cancer survey that was produced in 2011, also by MEPS, that I want to bring that cost in and then bring that value up to 2013. So that's for future. We know that unsupervised machine learning works, and it's definitely a precision medicine approach that should be used to make healthcare more efficient. This project was all about problem solving. I flew to ARC, Agency for Health-Related Research and Quality, back when we first started. Thought everything was great. I'm still waiting on data. So I don't think that's going to happen. I must have really pissed someone off. I don't know. But all these methods that I used were really new to me. So, I mean, it's just been a really great learning experience there. We do need other students to go forth and examine if these same comorbidity clusters are existing in other data sets. Also, there's an argument, well, that, based on your race and ethnicity, you're going to automatically report quality of life different. We don't know is that something we should be okay with, because if we're focused on the patient perspective, it shouldn't matter about their race, but that's up for debate. And then the whole cost thing. Again, rich data source. We have the cost data associated demographics, rigorous methods. Again, all the confidentiality thing with sample sizes, we just couldn't get a hold of a lot of data, so we had to use a lot of proxies. And the way MEPS work is that they don't pry you for diseases, it's what you tell them, so there could be a lot of underreporting of diseases. So my next step is to propose my dissertation in February and maybe get that done. Well, definitely get that done. And then hopefully I can stop being broke someday and get a job that allows me to go to my kids' football games. I don't know. So if you know a career out there that allows me to do this while conducting my own research, and my research interest is in how we can incorporate patient perspective into healthcare decisions. So I want to thank my mentor, Dr. Leslie Hinyard, Dr. Solomon, Camellia, and everyone at CEESP also for this wonderful opportunity to widen and deepen my skills.
Thank you. Questions, comments from Lorinette?
Don't be shy. I don't bite.
I may have missed this, but I'm still not sure how you're doing the analysis.
Okay, so I have the diseases, right? The way these clustering algorithms
The
work,
diseases means comorbidities or cancer.
Right.
comorbidities, everyone has cancer,
Right.
okay? I'm selecting, and I should also say, I selected these comorbidities based, I use the same variables that Dr. Elixhauser used in her comorbidity index as being really clinically relevant. When you put, the way these algorithms work, they work differently, and this is the reason for using multiple ones. Some are distance-based. So they're going to say, take a number of patients, or take the points. Say, let's think of it in points. And they're going to say, what's the next closest point in terms of distance?
What distance? What metric?
So there are multiple distance. I use the Jacquard distance metric, but I mean, you could, you can use a ton. So it's essential trying to get to the closest possible group, and it's saying, okay, now that we have a cluster, so say 2 points just clustered together because they're closest, that forms a cluster. Now we're looking for another point that we can cluster with. And it keeps doing that. It's an iterative method that keeps doing that until it identifies ones that cluster together and ones that are far enough apart that they don't fall within the same cluster. That's one way of doing clusters. Does that make sense?
Is this in effectively two-dimensional space?
Yes.
Where you have two axes on a graph?
Essentially, that's what it's doing in the background.
Okay.
And another way is a probability kind of base.
Okay.
Like, you know, if you have a high probability of being in one cluster, you're in that cluster versus the other.
Okay.
And it doesn't necessarily mean that a patient can have a similar set of disease and still be in the wrong cluster. Like, right, it's not like split down the middle, but it's just that you have a higher probability of being in cluster Z.
So for comorbidities, everyone is clustered or not, and those clusters mean something in what way? That's the question.
So specifically these clusters, from what I saw, just eyeballing, you had this really generally healthy group. Maybe they had hypertension, but that was really it. So I came up with 3 clusters, right? My second cluster was, they had some more comorbidities, but they didn't have any kind of mental health problems at all. They didn't have things like fluid and electrolyte disorders. Then my third cluster, they just had it all. I mean, so what we're seeing here, because remember I also controlled for the number of comorbidities, we're seeing it's not only about how many comorbidities you have. It's also about what's the combination of comorbidities that you have. Because then that's going to affect your care coordination, both on the clinician side and also the self-management side. So I do have to go back and, because this was just a decision tree, I have to go back and there's different things that you can, initial results. So I need to go back and the clusters might change.
The reason I'm asking is exactly the clusters might change, and that's my whole point, is that the way you construct the algorithm will determine the results you get, and so you're going to want to do some testing of different approaches, different algorithms.
And that's exactly the reason for having like 5 different algorithms on there.
So essentially a sensitivity analysis.
Yes, exactly.
Okay, thank you.
Thank you, Lorinette.